Introducing Dr. Saleema Bhaldani. Saleema Bhaldani is a clinical pharmacist and the Director of Pharmacy Innovation and Professional Affairs at Whole Health Pharmacy Partners in Toronto, Canada. Saleema graduated with a Life Sciences degree from McMaster University and a Bachelor of Pharmacy degree from the University of Waterloo. Most recently, she obtained her Doctor of Pharmacy designation after completing clinical rotations at the world-renowned Mount Vernon Cancer Centre in London, England. Saleema has practiced in a variety of settings. Her current role as Director of Whole Life Health Pharmacy Partners has allowed Saleema to explore and implement unique professional offerings in independent pharmacies across Canada. Under her leadership, Saleema introduced the concept of precision medicine into the pharmacy banner. She is actively pursuing and introducing new programs focused on the provision of individualized care to patients such as specialty medicine and pharmacogenomics. Apart from this, Saleema has formed partnerships with the Canadian Mental Health Association and Sick Not Weak, an organization based out of Toronto to fight the stigma associated with mental health. As a second-generation pharmacist, Saleema understands the strength pharmacists have in the Canadian health economy. She is heavily involved in the Ontario Pharmacists Association, the Islamic Pharmacists Association, and is a lecturer at the University of Waterloo School of Pharmacy. Saleema currently lives in Toronto and enjoys swimming competitively. She currently continues to practice in frontline pharmacy to apply her clinical knowledge and search for new opportunities to bring innovation to the profession of pharmacy. Ladies and gentlemen, please help me welcome Dr. Saleema Bhaldani.
Thank you so much. This is probably one of the liveliest pharmacy conferences I've ever been to. It's such a pleasure to be here today. This is my first time in Jamaica, and I love it. I'm only here for 2.5 days, and I have a flight to catch, and I think I want to miss it, so. So I'm going to be speaking to you about personalized medicine, and this is an area that I'm very passionate about, and there's 2 areas that I've recently introduced into our pharmacies in Canada, and I just wanted to share a Canadian perspective with you, and perhaps there's some similarities that you can find within your own practice of pharmacy. So this is the declaration. I really want to thank Apotex for sponsoring this. Everything in my presentation is independent, and the opinions are my own, but Apotex has supported this, so I want to give them a big thank you. In terms of conflict of interest, I did do a pharmacogenomics test, which I'm going to be sharing with all of you, and I received that free of charge, so I thought I would list that on there. And then I've done other speaking engagements as well. Okay, so a bit about me. As the speaker introduced, I am a clinical pharmacist, practice both in Canada and in the United Kingdom. And now I work for the head office of a company, of a chain of pharmacies. So just to put that into perspective, it would be like working at the head office of Boots in the UK or CVS or Walgreens in America. And so I work for a company that looks after pharmacies across Canada. And my goal is to bring innovation into pharmacy. And the reason why this is so important is because in Canada, at least, and this could be in other parts of the world, including here in Jamaica, there have been a significant amount of decrease in funds to what pharmacists receive. And so pharmacy isn't what it used to be. The profits that you get, the wages that you get when you graduate and you become a pharmacist, the opportunities that are there, maybe the benefits that you get, they're just not the same. And the reason for that is, there are many. A lot of it is because it's a publicly funded healthcare system and the government controls all of that. But we as pharmacists have the opportunity to create something that will help us move away from that and allow us to be viable and survive in this market and continue to help our patients in the best way. And the reason why this is so important to me especially is because it's very close to home. So that's my mom. She, like many of in this room, has been a pharmacist, and she owns her own small private pharmacy, and she's done that for almost the last 40 years now. And unfortunately, like her and pharmacies across Canada, everything is linked to the dispensing of prescriptions. So the more dispensing that you do, the more prescriptions that you fill, the better your income is and the better you're able to hire pharmacists and technicians and so on. But unfortunately, the way that our nature of pharmacy is now, even though a pharmacy may be dispensing more medications, there have been so many cutbacks that it's just not as profitable anymore, and that really suffers. It suffers the pharmacist and the patient themselves. And so when we're building programs for our pharmacies and we want them to do well, we have to think of two things. The first is, what's going to bring value to the patient that the pharmacist can offer? And number two, what is a new revenue stream that the pharmacy can have so that they continue to survive? And so the best person to ask are the patients. What do the patients want? And this is a survey that was done and published in the Wall Street Journal, and they asked over 1,500 people, what matters the most to your health care? And the number one answer was personalized care. So if it's what patients want, what can we as pharmacists do to meet their demands and really evolve into the future of healthcare? And so that's why I'm going to be talking about two different programs that we've rolled out in Canada very recently. And I'll start with pharmacogenomics, or what we call precision medicine. Okay, so pharmacogenomics. I'll go through this very briefly. What I really want to touch upon is the more clinical aspect so that you can relate it to your practice. So pharmacogenomics is a mix of two words, pharmacology and genomics. So it's how drugs work in relation to a person's genome and their genetic profile. And the purpose of this is to optimize drug therapy so that, first of all, your patient is receiving the most efficacious drug, and secondly, so that there is less of a chance for them to experience adverse effects. And that's sort of the backbone to what pharmacogenomics is. And so that means that based on someone's genetic profile, they will respond to a certain medication differently than others. And it moves away from this one medicine fits all approach, right? Because many times we've seen it. You've got 5 different people who are diagnosed with the same disease, and they're treated with the same medication, but all those 5 individuals are completely different from one another. So how does their genetic profile respond to the medication? So this is a bit more into the science. The reason that this is important, and I don't know if it's probably the same acronym here, but ADME, so absorption, distribution, metabolism, excretion. Yeah, okay. So metabolism is the one that we're concerned about when it comes to pharmacogenomics. And that's because more than 80% of the drugs that we take are metabolized by the liver, and specifically by your CYP P450 enzymes. And so the genes that code for those enzymes is what we're concerned about when it comes to pharmacogenomics. And that's because we have a population where we think what normal is, and it's what how everyone will respond to that one particular drug. However, we can have different alleles. Just like people have different alleles that code for eye color, right? They may have the alleles that code for blue eyes or brown eyes, and that's what makes us different. So the same sort of philosophy with our enzymes. We could have a drug that metabolizes, an enzyme that metabolizes a drug poorly or ultra rapidly, and it may not be normal. So the way you would know that it was normal is by this star allele nomenclature. So if it says star 1, then that patient has the normal allele. Any other number other than that, so for example star 3, then that means that they carry an altered function allele. So this CYP2D6 is a very important medication, and I'll show you an example because it's the one that metabolizes codeine into morphine, making it active. So just to give you an example, there are two functions of the enzymes. They can either make a drug active, like a prodrug, or what you may commonly know is they make a drug inactive. So they inactivate it and then it's excreted. So clopidogrel is a very well-known example of where pharmacogenomics is very widely used. And that's because there's a lot of different alleles that people can carry. In fact, in the African and the Asian population, those of African and Asian descent, their likelihood of being a poor metabolizer is about 10%. So that means 1/10 of the population could have an altered function enzyme. And this is why this is detrimental. Because if a patient is put on 75 milligrams of clopidogrel after an acute coronary syndrome and they've had a stent placed in, then hopefully the patient responds as you want them to, and that antiplatelet effect is working as it should. But if the patient is carrying this star2 alleles in their genes, then that means that they're not going to be able to convert, because it's a prodrug, the inactive metabolite to an active metabolite. And so that could lead to death because you're not getting that antiplatelet effect. So that's kind of the backbone behind this. And if you have any questions about the science, we can go through that in the question and answer period. But I really wanted to focus on more of the clinical implementation of what this looks like in pharmacy. So this is a true or false question. I think that you're going to have these in your quiz later on. Codeine is metabolized into morphine by CYP2D6. And that's a bit of a diagram there. And once it's converted to morphine, then it acts on the brain and has that opioid effect. So true or false, we'll do this now. An ultra-rapid metabolizer would likely have inadequate pain relief. So if your patient was an ultra-rapid metabolizer, okay, so they metabolized codeine to morphine really quickly, then they would likely have inadequate pain relief. Hands up for true. Hands up for false. Okay, yeah, so it's false. All right, so now I'm gonna move away from the science and I'm gonna go into how we selected a test. So in Canada, we had 3 options. Okay, so remember, I work at the head office of a company and we were wanting to roll out this program to our pharmacies so that they could offer these tests to their patients. So we had 3 options to choose from, 3 different companies. The first one was called Oneome, okay? The second, MyDNA, and the third, PillCheck. So I'm gonna go through the pros first, then I'll go through the cons, and then we can do a vote to see which one do you think we chose, okay? So the first one, Oneome. Oneome comes from the Mayo Clinic. Are you guys familiar with the Mayo Clinic from the US? Yeah. Okay, so it's very credible, very well known, and they've created a very good and thorough test. They test for a lot of different alleles and a lot of different genes. MyDNA actually comes from Australia, and it's a very inexpensive test. These 2 tests, 1 and 3, they cost roughly about the same, and I'll get to what that is. MyDNA is a bit cheaper because they don't test for as many different variations. But the neat thing about them is they offer specialized tests. So if your patient was only interested to know how their genetic profile will respond to medications related to their cardiovascular health, so your ACE inhibitors, your beta blockers, your statins, those types of drugs, then there's a test, a MyDNA specialized test for that. Even with mental health, if you wanted to understand how their genes metabolize certain mental health medications, there's a specific test for that. With these other 2 tests, you get all of the 150 drugs that they're testing, so it's not specialized in that way. The third is PillCheck. The PillCheck comes from Canada. Like Oneome, it has a very thorough test, and the neat thing about it is that they offer really good training and support for pharmacy because they really want to see this succeed in pharmacy. Okay, so let's go to the cons. So Oneome, like I said, it's expensive, but the other thing about it is that they don't offer as much training. And I think it's because, interestingly, in the US, it's the physicians that are offering pharmacogenomics. And in my opinion, pharmacists should do this because we're the drug experts, right? Yeah, okay. So they don't offer very good training for pharmacists in Canada, and it's really important when you're rolling out such a new innovative program to have that support. MyDNA, as I said, it's cheaper, and that's because they don't test for as many allele variations. And so perhaps the test that you're getting isn't as complete as you would want it. Pill check is expensive. So, and in Canada, people don't like to pay for things, right? We have a public healthcare system. You know, seeing the doctor is free, even though it comes from your tax money. People don't like to pay for things out of pocket. So it's hard to even get them to pay even $10 sometimes. So, okay, so we'll do a vote. Which pharmacogenomics, that's the short form, so such a long word. Which pharmacogenomics test do you think that we chose? So hands up for A, 1 ohm. Okay, nobody. All right. B, MyDNA. Okay, yeah. Or C, pill check. Okay, so there's a good mix between B and C. That was the hardest choice that we had to make because I know I don't get into my presentation, but one of the other focuses is mental health, and we're trying to bring mental health awareness into pharmacy. And so the fact that MyDNA had a mental health specific test was of real great interest to us. But the winner was pill check. And the reason is it came down to professional judgment. When you're making a recommendation and you're going to change someone's drug therapy based on their genetic test, you want to make sure that the test that you have is as thorough and complete as possible. You don't want missing information because that could lead to false positives, right? You may think that somebody is, let's go back to the clopidogrel example. You may think that somebody is a normal metabolizer because that's what their genetic test told you, but they didn't test for as many alleles. And in fact, they're actually a poor metabolizer. They don't get that antiplatelet effect. They get another heart attack and they die. So I wouldn't want that on my conscience. I don't know about you guys. No. So we went with the more thorough test. We went with the one that tested for more alleles. The other thing that was neat about it, well, because it's Canadian, we knew that when we sent the results in, we would get the results back faster, which is important for patients. They don't want to wait even more than 2 weeks for a test to come out. They want their results right away. Extensive training, and I'll show you what that looks like so you can get an idea. And they followed the CPIC guidelines, which is an internationally recognized guidelines that's becoming more popular as it relates to pharmacogenomics. Okay, so does anybody know what the cost of these are like? Okay, they're really expensive, okay? So this is what it is. So in your currency, 50,000 Jamaican dollars. Yeah, I'm not paying for that. I'm just kidding. It's expensive. And the way it works to the pharmacy is the pharmacist would get $350, and then they sell that kit for $500. So they're making a profit of $150, which is a good revenue opportunity. But this only works with patients who your test results will actually make a clinical difference. And some insurance companies are willing to pay for these, because if you think about it, if a patient is being put on so many medications and they have so many adverse effects, then maybe getting their drug right the first time could have saved money in the long run. So this could be a good investment. So that's the biggest barrier that we're experiencing so far is the cost. However, this test used to cost 200,000 Jamaican currency. Did I get that right? Yeah. But now it's decreased to 500. So we're hoping that it gradually decreases, but we want to be prepared for when that does happen and want to be ones for the knowns that actually implemented this first. This is what the training looked like when we conducted it with our pharmacists. We had an introductory classroom course based on the practical information. Then we did webinars, more science-based, 2.5 hours. Then every one of the pharmacists actually did a pharmacogenomics test, and then they all got together and shared their learnings. So I just wanted to share with you kind of what the training looks like. And the neat thing about PillCheck is they've got a medical geneticist who's the founder of the company, who's there at all times. If you have any questions, if you're unsure about a recommendation that you're going to make based on that, he's always there to consult with. So we thought that was nice. So this is what it looks like in the pharmacy. I actually have some of the tests, and I brought them for you. Okay, so this is what OneNome looks like. And PillCheck doesn't have a fancy box, but they have a little folder here. But the main thing in this is just this swab. So all you do is you do a cheek swab in here, you collect the DNA cells, you flip it around, there's a little bit of a solution here. I don't know if you guys can see that. Shake it up, and then you mail it back. That's all it is, and it takes 1 week for it to return. So you as the pharmacist, it's the same in this, it looks the exact same, the OneNome. So it's the same, that's all it is. So what you do, you as the pharmacist, you all have your counseling rooms, confidentiality corners, that's called? Okay. So you would meet with the patient in there. The first thing is who are your patients? Who are the right patients for this? Because, oh God, what did I do here? Okay, so who's gonna pay for something like this? It's not something that everybody should use at this point in time because it's just so expensive. So who are your right patients? The ones that I've listed on here are, like I said, those that are on medications that are not effective, that are experiencing toxicity and adverse effects related to them. Some of the biggest areas that we've seen are mental health. If you think about how long it takes for somebody to get on their medication and get the right one, then it takes some time, and then you have to wait about 4 weeks to see what the effect is. Imagine if you could pick the right drug from the beginning. That would be ideal. So this helps you get a little bit closer to that. Warfarin, I don't know how many of you pharmacists here manage warfarin, but I'm sure you see it on a daily basis, INRs fluctuating up and down. This can help you figure out what dose is most appropriate for your patient. There's lots of opioids, pain management, that's a big one. Trying to figure out which medication would work best for your patient's pain. So those are the people that would be most likely to benefit from some of these tests. The results would produce something meaningful for them. So you sit down with them in your counseling room, you speak to them, you complete a medical profile, they do the cheek swab, you send it in. A week later, you bring the patient back to your pharmacy, okay? And you go over their results. And then you make your recommendations, and this is the important part. You have to get this is what we've learned, at least so far. You have to get the buy-in from the physicians. If they don't know what you're doing, and many of them don't, they're not gonna take your recommendation, right? It's about them understanding that this is science-based. This is based on not going through this trial and error approach that we're used to, where one medicine fits all, and really that the recommendations are based on what the patient's genetic profile is. So even before you start this test, communicate with the physicians around you and the doctors around you that you're doing this. Because when it comes time to making your recommendation, I think that this patient should be on a higher dose of such and such medication according to their genetic profile, they're more likely to uptake what you're saying. Okay. It's 150 pages, so a bit overwhelming. Yeah, because it tests for so many drugs. I'm happy to share this with you. I don't mind. So they check for several different alleles. I've posted them up there, okay? And then you get a report at the beginning that summarizes all your medications into this lovely chart. So it tells you whether you should use certain medications with increased caution, mediocre caution, and then standard. So as in, I metabolize that drug in a standard fashion, like the rest of the normal population, but not these other medications. So if I were to ever be put on a PPI, right, for GERD, heartburn, I should stay away from pantoprazole. I would not respond well to that. However, rabeprazole would be okay for me. So now I know if I'm ever put on this medication, then rabeprazole would be the better choice for me. Does that make sense? Okay. So it's pretty neat that way, and they have it categorized in terms of psychiatry and especially cancer drugs. That's a big one. We don't tend to see that in the community too often. That's mostly in the hospital. So things like your pain meds and your mental health meds, your gastrointestinal meds, those are the things that we tend to focus on. There's a lot of pages to go through. So I just wanted to show you what that looks like. So this is an example of a case that happened in Canada. We had a patient, Miss J.H., 35 years old, recently diagnosed with depression. Her doctor started her on paroxetine, 10 milligrams once daily, but the patient discontinued it because of side effects. So inability to sleep, GI side effects. So she was recruited into the pharmacogenomics test, and she agreed to do it. And it came out that her pharmacogenomics test showed that she's a poor metabolizer. So what does that mean? That means that paroxetine isn't being metabolized as quickly, staying in her body longer, and then that's what leads to the side effects, right? You've got increased toxicity. So the pharmacist that was looking after this case, she made the recommendation to discontinue paroxetine, stop it altogether, the patient already had, and start escitalopram 20 milligrams once daily. So that's the recommendation that she sent to her physician. Again, she already had the physician buy-in from before, and that recommendation was carried through. So clinical pearls, this is what we've learned so far for it being into Canada. Pharmacists have the opportunity to do this. We are the drug experts, we're knowledgeable, we've learned about this. Physicians have taken like one course in pharmacology. That was our education, right? We focus on pharmacology and understanding drugs. So this should be no different. We know how to interpret. With good training and an understanding of what pharmacogenomics is, we should be able to do this. Choose a test that evaluates a large number of genes. I've mentioned that. Training is important. Ensure the most appropriate patients. The biggest benefit that we've seen so far, pain management, mental health, GERD, and stroke prophylaxis. A common question that patients will ask you is this going to affect my insurance, right? But this doesn't give you any disease info. It doesn't tell you if you're more likely to have Alzheimer's when you're older or more at risk for cancer. It doesn't do that. It simply tells you about your genes. So there's less of a stigma associated with it. So patients aren't really concerned about how this will affect their insurance rates. Take the entire patient into account. If you have a patient and you've done a pharmacogenomics test and it tells you that the patient should be started on, let's say, 5 milligrams of warfarin, but they eat a lot of vegetables or they're on certain medications that could impact their INR, those are other things to take into account. So just because the test says it doesn't necessarily mean that's what you have to go by, because you have to look at all the other factors that come into play. The biggest barrier is cost, but remember that the results are good for life. Once you do this genetic test, my results are not going to change. I'm always going to be a poor metabolizer or a rapid metabolizer rather of pantoprazole, and that drug is never going to be effective for me. So the results are good for life. So, it may be an upfront cost, but it won't change essentially. So this is the last slide to this part of the presentation about pharmacogenomics. What's next? We could come to a point where a patient comes up to you, they hand you a diagnosis. My doctor has diagnosed me with depression. And then they also hand you their genetic profile and say, choose the right drug for me. Never know. And there have been instances where drugs that currently got off the market due to side effects are now re-emerging because pharmacogenomics has told us that this certain population actually responds well to this medication. So we could see the re-emergence of new drugs as it relates to a person's genetic profile, and they'll have to get tested first. So that wraps up this segment on pharmacogenomics. I'm going to move on to the other program that we've been focusing on, and that has to do with precision counseling. Have any of you here heard of the appointment-based model, ABM? I think that's what you call your bank machines here, right? ABM? Okay. Not that one. So ABM is a model that we have stolen from the US. It was started by a pharmacist in California 20 years ago, and it's spread across the country. There are over 22,000 pharmacies in the US that have adopted this model. So it's about 1/3 of all the pharmacies in America that have adopted the appointment-based model. The good thing about it is that it's free, so that's nice, contrary to the last part. And when we were bringing it over from the US to Canada, They offer all these manuals and training manuals for free. You can just look them up online simply. And so we looked at all the information available out there. And when we were bringing it to Canada, there were things that we had to change because there are certain things that didn't work in our country. So as I'm going through this, what I'm presenting to you is what is working in Canada, but perhaps you can think about ways that it would work in Jamaica, right? Because that's what we did when we looked at what was available. So I'll start with this. Does this describe your pharmacy? You've got a lineup of people waiting to speak with you. You've got the phones ringing off the hook, right? You've got someone in front of you that's upset because you don't have their medication because you just gave it to the last person that was in there, right? Okay. So imagine a program that could help get past this and allow you to be more proactive and allow you to manage this a lot better. So this gets us there. This is the appointment-based model. So it's a patient care service, and it's designed, the number one goal for this is actually patient adherence. The benefit of how it improves your pharmacy efficiencies and your operations is a side benefit, but the number one is adherence, because who are we concerned most about? Our patients, right. So it takes the model of this reactive approach, people, bombarding you at all angles, to a more proactive approach where you, as the pharmacist, are the one that's managing this and controlling when your patient gets their medication next. So there's 3 components to this, and then I'll go into more detail. The first is prescription synchronization. Do you do prescription synchronization here? Is that something that is done? No. Okay. It wasn't in Canada either. It's not in Canada. We're bringing that there. So the backbone to this is prescription synchronization, lining up all of their meds so they all are due at the same time. Okay, I hear some groaning. That's not going to work? Okay. Yeah, okay, good. Okay. The next is the pre-appointment call. So the pre-appointment call prepares you for the appointment. And this is an appointment that you as the pharmacist will have with your patient about 5 minutes, 10 minutes, not more than that. And the call before is something that, for example, a technician will take care of. And I'll go through what that means, but there's the pre-appointment call and then you've got the appointment. So this is what it looks like. In Canada, we have refill prescriptions. So a doctor will say, right, metformin, 2 tablets twice a day, for 30 days, and then an additional 2 refills. And the prescription would stay at the pharmacy. So the patient would call you every 30 days to fill in their next set of metformin. So it could be different here, but patients always bring you new prescriptions. So the first thing is, if this is a patient that you think would benefit from this program, then you would enroll them. So who would benefit? Well, patients on 3 or more medications, they would benefit, right, because they're taking so many different medications and they could be unaligned. By disease state, so one of our pharmacists actually ran a report through his pharmacy system for all patients who are on metformin, so essentially screening for all his diabetic patients, and asked them if they wanted to enroll in the program. So once you've identified the patient who would benefit, and they signed the consent form and now they're enrolled, and by the way, the lingo that we've learned is, this doesn't work. Would you like to enroll in our ABM program? Like, what is that? Right? They don't get it. But if you say something like, would you like to pick up all your medication at the same time? Yeah, okay, that sounds good. So just using lingo like that. Once they've enrolled, by the way, we haven't had any pushback from patients enrolling. They all really like the concept of having more meaningful time with their pharmacist. Then you synchronize their medication. And this is an example of what that looks like. So pretend today's date is October 6th, okay? And the patient comes to you to fill medication A. The first thing that you notice is that medication A is late. So they haven't picked it up for the last 5 days. They haven't been maybe not taking that medication for 5 days. That's the first thing. So I'm looking at this red box here. You then notice that in 13 days, the patient is going to come back to you to get their next prescription, medication C. And then the patient is going to come back, and then 22 days from now, also the patient's going to come back and fill medication B. That means in the month of October, this patient has come to you 3 times. So this is why you have lineups, right? It's contributing to that. So imagine if you could synchronize all of these medications from the beginning. So keep in mind that when you do this, you're going to be filling for odd quantities, right? Medication A, you're going to fill for 22 days so that it lines up with medication B. And medication C, you're going to fill for 9 days so that it lines up with medication B. So when medication B is due, you're now filling all 3 meds at the same time, and then you schedule that for, let's say, a month after, and again, they're picking up that prescription all at the same time. Okay? So let's do a question here, just raising your hands. This is not something I've talked about yet, but it's just to illustrate a point. Mr. Edwards has the following medication profile. He's on atorvastatin once daily, bisoprolol once daily, ramipril once daily, and his salbutamol inhaler as needed. So true or false, so is this statement true? Not all of these medications have to be synchronized. Yeah, true, exactly. And the reason is because it's hard to sync salbutamol, right? The patient doesn't take it every month or every 3 months if they're only using it as needed. So you have to sit down with the patient and really look through their medication profile and ask them which ones are they taking on a chronic basis and which ones they would want to sync. So then you prepare for the appointment. So now let's pretend October 28th happened and now they're coming back in a month, so September 28th, let's say, to fill their next set of prescriptions. 3 days before that, you would have a technician or an assistant call the patient and say, "Hi, Mrs. Jones, I noticed that your prescription is running low. Would you like to fill all 3 prescriptions?" If they say, "No, I've got lots at home," then you know that there's something wrong because they should have taken it, right? So this is where you can catch that adherence. And then you can ask them other questions like, "Have you been to the doctor recently?" We know a lot of patients will see their doctor and the prescriptions that they get will never come to your pharmacy. They're abandoned, right? This is a way to catch those prescriptions. So you prepare, the technician prepares, they fill all the medications, they make sure that they have enough stock to fill these prescriptions because they know they're going to fill them in 3 days, so you order the right number of medications ahead of time and you don't get into this balance owings or anything like that. And then it comes down to the appointment. So this is where precision counseling comes in because you've already gathered all the information as it relates to that patient. Then you as the pharmacist sit down with the patient in your counseling room, which in Canada, it doesn't get used very often because we're so busy, right? And so you sit down with the patient and you do what you as a pharmacist were meant to do and what you were trained to do. We weren't trained to count pills and put them in other bottles. No, we were trained to help our patients. And this helps you do that. And if you're wondering, where am I going to get 5 or 10 minutes to sit down with a patient? I'm so busy. If you enroll more patients to this, then it gives you that more time because you've already synchronized and you've improved the operations within your pharmacy because it's now more proactive. And during that time, you can ask, review inhaler technique. A big thing that we've seen is asking about planned vacation time. So many Canadians escape the winter because it's terrible, and they'll come to warm places like this, and they'll come to us a day before and say, "I need 6 months worth of my medication." You may not have the stock to fill that, but if you're having these appointments regularly, your patient may tell you, "Oh, actually, I'm going to go to Jamaica for 6 months, and I need that quantity of medications while I'm away." Okay, now we can prepare for that. Also, you can make over-the-counter recommendations. Again, increasing the revenue to your pharmacy. Not only are you filling medications that wouldn't have been filled before because your patient was non-adherent or they never even brought the prescription to you, you can also make other recommendations that the patient may need in terms of over-the-counter products. These are the benefits of ABM. I've talked about the pharmacy. These are all proven in evidence, and I'll show you this in the literature. To the patient, it actually provides a more meaningful interaction between the patient and the pharmacist, and they have a better satisfaction. And for the prescriber, it allows you to improve coordination of care depending on your relationship with the prescriber. Okay, so true or false? Miss Singh has a hard time remembering to fill her levothyroxine each month. True or false? Miss Singh cannot enroll in the ABM program because she's only taking one medication. Oh, that's so good, yeah. It's false. Because, fine, you may not be lining up all her medications, right? She's only on one, but she could benefit from the extra coaching and the extra attention that she would get from her pharmacist. It's good. This is the evidence. I've just pulled various articles that actually prove that the ABM model increases adherence rates, they increase patient satisfaction, they increase revenue to the pharmacy, they allow patients to have better control of their medication. There's a lot of evidence, yes, from the US, that have backed this up. And now that we're doing this in Canada, this is something that we're studying to see, does this work in our country? And anecdotally, I can tell you that it already has. This is the training that we provide. So what we did is we changed the name of this program, and we called it the Wellness Plus program. So this is our manual. And we call it Your Modern Approach to Pharmacy. And we took all the learnings that we could from the US, adapted it to our country, and then trained all our pharmacists on this model. So we did a 1-hour intro webinar, and then an hour and a half more on the specifics and case studies. And then we would do weekly and bi-weekly follow-up calls just to ensure the program was running successfully. And then we had a group call with all the pharmacists who have initiated the program. And it's interesting because they all got the same manual and the same training, but because everyone's pharmacy is so different, I'm sure it's the same here, though there have been some tweaks within the pharmacy. And so everyone has sort of adapted it even to their own pharmacy within Canada. So this is what we've learned so far. The number one thing to make this successful is to ensure that all of your staff are on board. It requires a whole team approach. And it is difficult at first to change your mindset from your patient used to call you when they needed their medication and come to you. Now you're contacting them on your own time. It's something that we may not be used to, but getting all the staff on board, recruiting patients, is critical to this. Selecting an ABM champion, one person at the beginning to lead this, has also been shown to have success in this program. You can even, like I said, consider having even patients who are on one medication. Some of our pharmacies created a target. So every week they said, we're going to enroll 5 patients into the ABM program. The best part about this, like I said, is it's free. So if you go into Google and you look up American Pharmacists Association ABM, you will find this model for free. You'll find their training modules. You'll find everything on there for free. And the MedSync calculating so that you can sync it. In the States, people have made pretty good money because they've come out with some fancy software that does it all for you, but you can just do it by hand. We all know how to do math. You can just do it by hand, and what we did is we just created, on Excel, we just created our own calculator, and that's free as well. So you don't have to pay for fancy software in order to do MedSync. This is win-win for everyone, and these are 2 quotes from our pharmacists that I really like. The first one is, I am now becoming the pharmacist I was trained to be, and we should have done this a long time ago. So I'm going to end off this part of the presentation with, but we've always done it this way. And yeah, everything is sort of been done the same way in pharmacy, but now things are changing, and perhaps it's time for us to change too. And perhaps there's a better way to look at the way that we run our pharmacies and the way that we offer care to our patients. So with that, I'll leave it with this quote. This is from a Canadian physician, very well-known physician. And essentially what he's saying is, because there's so much variability in individuals and we're all so different, the act of medicine is not just a science, but it's an art. We really need to look at the personalized, the individualized care of our patients, and we as pharmacists are drug experts, we're knowledgeable, we know about medicine, and we're very accessible to our patients. So in my opinion, we should be the ones to offer this. Thank you. Does anyone have any questions?
Thank you, Doc, for thank you for such an informative and lively presentation. It has been said that about 30% of persons who are on statin, it only works about 30%. What does the genomics have to do? Does that have anything to do with that?
It does, actually. That's a very good question. So he's asking about statins and that people don't tend to respond to it very well. And that's completely the case because of pharmacogenomics. We've seen that patients are either ultra-rapid metabolizers, poor metabolizers, intermediate metabolizers, and they don't respond to statins the way that the trials have shown that it should. And then that's why how you get cases of rhabdomyolysis and these really bad side effects and muscle pain, because they could have increased toxicity to it. So it completely has to do with pharmacogenomics because it's metabolized by the liver. So good question.
Hi.
Hello.
My name is Toby Wilson. Currently, I really freelance, but I've realized in a lot of the pharmacies that I've been that they try to adopt this model in some way or form, especially the slower pharmacies. And a lot of the times I realize that the patients aren't very receptive to it. After about 3 months, 4 months, they start saying, oh, I remember, you don't have to call me, you know what I mean? So how do you integrate it into your pharmacy? Because a lot of the pharmacists can actually benefit from it. And I've seen where a lot of them do, because they now develop their patients and have them regularly. But some of the patients are not so receptive after a while. They become very aggressive.
That's a good question. I'm glad to hear that elements of this could work here in Jamaica. If your patients aren't as responsive 3 to 4 months down the line, then that's completely fine, because you still have control over their medications, and perhaps they don't want to actually sit down and sit with the pharmacist and they're okay from that sense. So that's fine. The initial appointment for this may be close to 20 minutes, and then gradually, as the months go on, maybe 5 minutes at most. So that's okay. The main goal is to make sure that your patient is adherent and that they're following the medications as they should. And so if they're not seeing you as regularly, that's okay, as long as you as the pharmacist know that they're okay.
Thank you so much for such an informative presentation.
Thank you.
So I've been a pharmacist for a number of years now, and what I've observed is that there's always a competition between practice and profit, especially with pharmacy owners who are pharmacists.
Mm-hmm.
So I'm wondering, with this implementation of the ABM model in Canada, has the insurance company come on board? Because now the pharmacist will be spending extra time with the patients, and you have so much more to be doing. So how does the pharmacist get more paid, or does the pharmacy get additional benefit apart from those that you mentioned?
That's a good question. One of the reasons why this model works well in Canada, and especially in where I'm from in Ontario, is the pharmacist actually gets paid by the government to sit down with the patient once a year and go through their medications. I don't think you have that here, right? No. Okay. Sorry. We only recently got that. So that provides an extra revenue stream for the pharmacist, because they can sit down with the patient and actually bill for that. But to answer your question about insurance companies, that will only qualify for people who are seniors, for example, who are covered under the, we have free health care, but we don't have free drug care, right? It's similar here where seniors get their drugs for free, and then certain other segments of the population. So insurance companies are catching on, but because this is such a new model, it hasn't come in yet. However, some insurance companies are paying pharmacists to look after their cardiovascular health. There's an insurance company called Green Shield that has a cardiovascular coaching program. And they would pay pharmacists to actually sit down, and they're the ones who are recognizing that pharmacists should be the ones to really manage those with chronic diseases. And so I think we're going to see more of that, and ABM will help facilitate that. The other thing I wanted to mention, based on the presentation before, was remember how we talked about the PHQ-9 mental health score? Because mental health is a big focus for us in our pharmacies, during that appointment, that's one of the suggestions that we made. Do a PHQ-9 on your patients so that you can screen for any mental health issues and then speak to their doctor about that. It's a good way to incorporate those screening tools. And someone asked a question about what would be the role of that in pharmacy, so that's a way that you can incorporate it. Thank you.
I would like to express my gratitude in such an informative presentation. I'm sure persons here learned something from what you presented to us today. Thank you very much.